I'm Heidi Greata, and I'm presenting today with my colleague Courtney Matrunick. We are physical therapists at UNC in Chapel Hill, and specifically we're at UNC Health and the Thrive program. And today we'd like to talk about physical therapy's role in clinical advances in future directions specific for long COVID. We have no disclosures. And just to give you a map of what we plan on covering, we'll start by looking at the latest research on exercise and physical therapy's role in managing those symptoms. We'll touch briefly on rehab-specific goals for each system, with a primary focus on vestibular recommendations. In the crux of our time, we really want to focus mostly on post-exertional malaise and the areas that are currently lacking in the research. So when we talk about the definition of long COVID, it is a, a process that has symptoms that last for at least 2 months, that can't be explained by any other diagnosis. And we know it affects multiple systems, but the primary complaints that we're hearing in PT are fatigue and shortness of breath. And the Journal of Public Health in 2021 put out a great illustration demonstrating all the different systems that can be affected, and also demonstrating the potential benefits of exercise for each of these systems. So if we look more closely at physical therapy, Zhang took this a layer deeper in 2023 by reviewing 9 randomized controlled trials where they looked at studies with over 1,500 adult participants. And in these studies, they use multimodal exercise-based rehab occurring between 2 and 5 times a week for between 2 and 12 weeks. And what they found was that supervised multimodal exercise, primarily aerobic, Tai Chi, or breathing exercises, did show targeted benefits in several different areas, from depression to shortness of breath, anxiety. And the only adverse effects were really affecting people who had had an ICU admission during their COVID-19 infection. A few other minor adverse effects happened, and they stressed in this study that it is important to make sure that these exercises are supervised. Again, just stressing the importance of rehab-based care and not just general return to the gym type recommendations. They also highlighted that the unique symptoms that were not addressed or needed further study were those post-exertional symptom exacerbations, and Courtney will talk more on this in a little bit. So if we look specifically at the general treatment path and goals for each system, we've laid out a couple different maps for each system. When it comes to pulmonary complaints, and Courtney, we can slow down just a little bit.
Sorry.
You're good. So patients with shortness of breath, really what we're focusing on is, can we help them recondition and can we work on breath work? Sarah mentioned this a little bit, but there is a lot of diaphragmatic breathing that occurs with this. And speech therapy also plays a really big role. Sometimes they also work on pace speaking, resonant voice therapy, and posture coordination exercises as well. And we can go ahead for the next part. I'm going to add a lot of slides in here. We're not going to go through them in the interest of time, but we did want to include this information for future reference if anyone wanted to go back and look more at the processes and the tips that we use for our patients. So for breath work, again, we focus a lot on diaphragmatic breathing. For reconditioning, we use the modified Borg scale on a scale of 0 to 10, and we also educate our patients on the rule of tens. So helping them increase their exercise endurance and intensity by 10% at a time. The second system or second impairment that we see frequently is dysautonomia. And there's general dysautonomia and there's also POTS, and we see that all the time in our clinic. We emphasize that even though POTS specifically isn't necessarily a cardiovascular condition, cardiology and PM&R, physical medicine and rehab, are the main specialists that help us drive this care. And just as a matter of who they can get in with first is who we recommend that they start treating with. But we do work multidisciplinarily with them. Our main focus when it comes to physical therapy is, again, improving that heart rate variability, that exercise tolerance, but also looking at standing stroke volume. And occupational therapy focuses a lot on the four Ps that were mentioned previously, like the pacing and the positioning. They also focus a lot on compression and hydration. And so if we look more specifically at POTS, Courtney has done a lot of work in trying to parse out exactly what type of exercises are tailored to this population. And we do follow the Levine study and the CHOP protocol some, but I want to emphasize that we have found that if you use those as a recipe instead of a guideline, it can actually be harmful for patients. They both have pretty rigid timelines, and we use them more as just recommendations of, hey, what is the next step? But we definitely let the subjective feedback from the patients drive the timeline for each of these. The NASA lean test is an easy screen that we can use for patients who we suspect may have POTS. And then as far as treatment strategies, we are providing just a list of each area, how you would give them opportunities to improve their stroke volume in different positions. And we just really hone in on that. You don't want them sleeping more than 12 hours a day, which can be hard in a long COVID population. And also compression is really key. Again, looking at the Levine study versus the CHOP protocol, it can be difficult to figure out like, hey, which one should I lean towards? Because they're similar, but they are different. And I will mention that the CHOP protocol tends to be a little more flexible. It's more function-based and it's more pediatric driven, whereas the Levine study is more adolescent and adult driven, and it's a little bit more rigid. And this slide shows a little bit more of the protocol. It does push a lot of recumbent exercise first, a lot of core stabilization before moving on to those standing exercises. Now, as far as neurological insults, the primary ones that we're seeing in clinic are ataxia, a lot of paresthesias, small fiber neuropathy. But I also want to note that I have seen as a vestibular therapist signs that are consistent with what we would think textbook BPPV. So a rotary nystagmus being recreated with positional testing, and the nystagmus is very evidently fatiguing when we test it with video oculography. And these individuals don't always track as BPPV. I've had people come in and they spontaneously suffered a TIA, and we found that after the fact. So that's just some food for thought that I've learned anecdotally. But in general, when it comes to more neurological insults, we're focusing mostly on balance, safety, and helping them just return to general function. And OT is teaching them more just compensatory strategies. So vestibular impairments. I will note that over 40% of patients with long COVID present with some type of vestibular complaint. And BPPV is the primary complaint that we're hearing, which is not surprising given the fact that any increase in inflammation to that terminal line of blood flow for 15 seconds can produce BPPV, but it's not the only one. And we heard a little bit more about vestibular migraines previously. I want to touch on the fact that dizziness is not necessarily a room spinning vertigo. It can present, and I see this very frequently as I'm here, but I'm not here all the way. I'm disconnected. I feel a little wishy. My feet don't feel stable if I'm in the dark, or I just have this vice grip headache. And so, from a functional standpoint, if all medical options have been ruled out with neurology, ENT, and audiology, we focus mostly on just sensory reintegration. And so when it comes to sensory reintegration, we go back to the idea of, hey, maybe when you had COVID, one of your orientation systems was insulted, right? And if that occurs, then your body tends to trust it less, and you can develop what we call a sensory phenotype. So if you rely on vision, your vestibular system, and somatosensation for staying upright, those three systems have to work proportionally. And the silly analogy I use with our patients is it's very similar to eating a steak dinner, where you typically have a fork, a knife, and a spoon. if I were to take one of those utensils away, you could still physically get that steak in your mouth. However, it would be a much different experience for you and anyone you're sharing that meal with. The same thing goes for our orientation. If we're visually dependent due to a lack of somatosensation related to some neuropathy, or if we're struggling with some oculomotor tasks, then our orientation is going to become more taxing. And it just adds to that neuromuscular fatigue that we see so many of these patients dealing with. I do use SOT testing in our practice. However, this can also be conducted with a modified CAT-SIB very, very easily. And the one thing I want to point out in this slide is the two graphs on the left-hand side are SOT results. And if you look at these graphs, these individuals have relatively good balance. But the graph on the top demonstrates that when that individual is standing on solid ground with their eyes closed or with motion around them in a visually disturbed environment, that's when they start to struggle. That struggle is very nuanced, but this is a perfect example of someone who would classify as a visual vestibular phenotype. And they probably are working and functional and completing most of their tasks that they need to complete, but they're also probably hitting that wall by mid-afternoon, and is coming out as more of that brain fog. So this is the number one phenotype that we're predominantly seeing. And just to wrap some things up, I did add two decision trees, if you will, looking at more persistent dizziness versus episodic dizziness. And the one thing I'll point out is that we are utilizing VEM testing more than previously to help parse out if there's any weaknesses in that superior or inferior branch of the vestibular nerve, because what that can help us do is know if we should be driving exercise that is ventricularly stimulating versus saccularly stimulating if someone has a slight impairment. And I'll pass the floor to Courtney.
Okay, so one of the things that I find difficult and frustrating is that there is about 75% of people that will go in and do their physical therapy and feel great in the moment, but then later on they go home and they are completely wiped out. They can't do anything else functionally. And that is related to post-exertional malaise. So it's very, very, very important that that is the first thing that we as therapists are evaluating. And it is something that can be easily done, in a doctor's office as well. Just by definition, it is, that crash, that relapse, or that collapse. It's basically a delayed or disproportionate worsening of symptoms following a physical, cognitive, emotional exertion that previously would not have been a problem for these patients. And it cannot, and this is extremely important to know, be explained by a lack of fitness or psychiatric cause. So it is an actual pathophysical response, pathophysiological response. And there are a lot of great studies that I have looked at through the Workwell Foundation that really emphasize that fact. It's something that can last, 24 to 48 hours or longer. It doesn't pop up sometimes for 72 hours. So it makes it really difficult as therapists for us to recognize if the things that we're doing with our patients are actually the cause of their malaise. This particular assessment is something that we provide all of our patients when they first walk in the doors, before we even reach them, because it can really guide us into how we're going to question, how we're going to educate, and then what goals we should be really setting in that moment. It is something that was meant more for those with myalgic encephalomyelitis, because post-exertional malaise is a hallmark sign of that particular diagnosis, but it works very well for us, and we have found it very useful in kind of making sure that our patients are getting the best care. In our clinic, we've sort of spaced things out into two stages. The first being very focused on pacing, with the goal to reduce the crash that these patients are dealing with, both in frequency and intensity, and help them to improve their quality of life. Once we've sort of reached what I call a monthly, they are in a good space for a month, they've got more good days than they have bad, then we're ready to start reaching towards more activity challenging. So we're trying to increase that tolerance to activity. And I'll go into two things that I use here that have been really helpful for me. But another way to look at it is to see, on this chart, this was one done by Davenport et al., and it's a really great way to kind of break it up. The first A and B show where the patient had their illness, and then they started having a lack of tolerance for their activity level. So they go into this crash and push cycle. We sort of step in at C, where we're talking to them about you need to pace, you need to really self-manage some of these things. And then as they start having a better tolerance for their activity level, that's when we're going to start introducing some exercise interventions. I'm not going to go too much into energy conservation, but I do think the most important thing to note here is aggressive rest and vagus nerve exercises. These have been extremely helpful in helping our patients to pace throughout the day without avoiding activity, because that is not what we want them to do. And then these last two things, heart rate monitoring, I find it very helpful because we're trying to keep them under that anaerobic threshold and not go into an aerobic response. This I have found challenging just because when you start following your heart rate, you do start to become anxious when it gets a little higher. So I have started using heart rate variability, which I have found extremely helpful in showing the patients how to guide themselves based on hourly measurements, and it really focuses on their stress at that moment. One of the apps that I find super helpful is Stress Monitor, and that's the picture that you have there on the right, where it shows it in colors rather than numbers, because numbers sometimes can also be very triggering for anxiety. And my goal here is to help them recognize when you're in a red space, then you need to do some things like parasympathetic response, breathing techniques, or maybe even some vagus nerve exercises. If you're in the green or the blue, maybe now you can trial some exercises, starting with some core things. So takeaway points. Hopefully we were able to quickly. This was really fast. But the first important piece is making sure that our patients are not dealing with post-exertional malaise. If they are, then we need to be recognizing that pacing is their first goal, and we avoid graded exercise at all costs. For those people that are dealing more with autonomic dysfunction, we need to make sure that we're assessing to help with POTS, and make sure that we are really looking at, I believe somebody else mentioned the fact that this is a multidisciplinary space. So working closely with all of the practitioners is extremely important.